at birth was 29.6. Gestational age range between 23 and 38. Mean birth weight was 1.26 kilogram. And birth weight range from 800 grams to 1,950 grams. So results, screening location, that's another important thing. Most of the screening were done at the clinic. You can see 64.9%. Neonatal wards were only able to do that for 35% of cases. And there's some reason. Some of these people were so sick that they did not even allow us to, to do the examination. Okay? So, results. ROP was detected in 9 patients, 12.2%. 2 of these had threshold ROP. Both were treated. Now, at this time, there was no indirect ophthalmoscopy laser in our center. Okay? And some of these were bleeding. And we noted that, what do we do? Okay? So, the only option then was to give intravitreal anti-VEGF injection. And surprisingly, within a week or two, all those bleeding stopped. We are still following them up till now, and they have not recurred, because we know in the literature that we should watch out for recurrence. Mean birth weight of ROP infants were 1.14 versus ROP-free infants of 1.28. Mean gestational age of ROP infants was 29.8 weeks versus ROP-free of 29.6. So, these are one of those cases that we saw with early stages of ROP. You can see that demarcation line was captured. These are our pediatric ophthalmologists that are screening the baby in the neonatal ward. This is another one, and you can see that demarcation line. You can see hemorrhage in the retina. Now, challenges that we noted: lack of awareness. We needed to educate even the workers, the neonatal unit, the neonatal ward, the parents. Most of our patients in this environment are virtually, they have no knowledge about retinopathy of prematurity. In the neonatal ward, we noticed there was lack of equipment like pulse oximeter, even to measure the oxygen saturation. In some situations, we had to go to anesthesia to get to determine those ones. Suboptimal communication between neonatologists and ophthalmologists. Okay? Even there are situations that we are ready to screen and they say, no, today we have so and so to do. So we really needed to bring them to a meeting and say, this is what we need to do. Slowly dilating pupils of some infants, we need to take note of that. Parental consent. Some mothers are not willing to wait for eye exam. They say, no, cannot look into the eyes of my babies. You know, some of cultural practices, some religious say, no, you pray about it, everything will be okay. Even when you tell them the risk factors are there, and you show pictures, you show, they still say no. So in our environment here, we really needed to talk to religious people, to talk to people, because some of our people believe to listen to religious bodies before they can comply. Okay? Then, logistic of rescheduling follow-up exam in our environment too is another. Most of our patients follow up. Once the baby is born, naming ceremony is done, that's all, until you want to give an immunization. So we really have to take note of all these challenges. So incidence of ROP in the study so far, the study is still going on, is from LUT is 15. However, proportion of treatable to ROP is less in our study, 2.7 to compare to their own of 7.5. No significant difference between the mean birth weight and mean gestational age of infants who had ROP compared to those without ROP in our study, which is similar to one in LUT. Retinopathy of prematurity is becoming a public health problem in Nigeria. Improvement in obstetric and neonatal care with judicious oxygen use is very important. There is a need to establish ROP screening program in all neonatal units across the country. So I'm challenging some of us here today. By the time we get back to our center, please, let's initiate, because we come from, some of us are from tertiary centers. We have neonatal ward, you have the ophthalmology department, you have obstetric and gynecology department. So please get together and start something to establish a program. So that, and we are hoping that by the time you screen, there will be advocacy to provide treatment modalities. Thank you very much. Okay.
No, the ASI. Oh, you want to do the
No, let's do the book after that. Should we do the book now?
Let's do it.
Okay. Thank you very much. I just have 5 minutes to talk about the book.
Wait.
Yes, sir.
Sorry.
Yes, sir.
Yes. We want maximum effect.
Okay.
This book launch is scheduled in the major program of plenary tomorrow. It may be suboptimal if we start it here. Why not at the main session, let us give it to have maximum effect.
Okay.
Except if you feel otherwise.
Okay.
But it's in the,
Yes.
is it part of the
It's part of our
program?
retina subspecialty.
Okay.
Just to, not to launch, sir.
It will
Just
whittle
to,
the effect of measurement plenary.
Today's zone is not a launch. What he wants to do is just to introduce it to
our members.
us. We thought that it won't be good that it's a book on retina and then we
Society.
know nothing about it. So this is not a launch. He's just going to tell us about.
Thank you, sir President. Because tomorrow our chairman will be talking to us, the whole house, on the book. My own is just to let our members know why we are trying to present it.
It's okay.
Thank you, sir. Okay. So, why are we talking about loss of retinal disease in Nigerians? Because I know from time past, we've been relying on images from outside, even to teach our students, medical students, residents. We rely on pictures from outside. We say our popular textbook, if you want to see diabetic retinopathy, go to so and so and see. So that's what informed our saying, why not take our own picture, compile them together, and based on evidence, put some things by the side of those pictures so that students can be better informed, and also our general ophthalmologists. So that is why, so the pictures in those books are actually Nigerian pictures, okay? They are taken from Nigerians, and some of them are taken by the author, okay? Using cheap technology, using the mobile phone and 20 diopter lens, okay? So all these pictures we are looking at are taken with that. So what are the contents? We started with introducing retinal tears and retinal detachment, retinal vascular diseases, diabetic retinopathy, hypertensive retinal diseases, sickle cell, very important in our environment, age-related maculopathy, which was initially thought not to be relevant, but we are having them, a lot of them coming up now. Idiopathic polypoidal vasculopathy is another important presentation in Nigerians now. Okay, so we have them there. Hereditary diseases, toxic retinopathy, especially chloroquine. In our environment now, we know that some of our artisans are still using chloroquine as if they use it to prevent malaria. And they use it every day. And what happens is that at the end of the day, they come to you, the macula is gone. Okay? We also talked about macular holes, vascular retinopathy, toxoplasma chororetinitis, toxocara, tuberculous retinitis, cytomegalovirus. We are seeing them now. In those days, they used to say, no, we don't have it here, our people don't survive. Now, they are coming, and we are seeing them. Okay, retinopathy of prematurity, we have discussed that. Trauma, retinal malformation, optic pits, all those things, we are seeing them now. Melanocytoma, retina in chronic renal failure. And part of the book again, we also demonstrate how to use your phone to take pictures of the retina. It's also there. And we also discussed some major retina studies, okay, that can inform management. Major ones, not all the retina studies. Those on diabetes, retinal vein occlusion, okay, the major intervention studies and current anti-VEGF studies were there. We also talked about using mobile phones and all the pictures, and we also talked about retina studies that were done in this environment, especially in our center. And I hope we'll be able to use that to further teach our students and residents. Thank you very much. Okay.
You can set up.
Yeah, thank you, Jeff, for your presentation about ROP. But let me say that, maybe you mentioned it or your Zoom. There was an earlier study on ROP in Ibadan by Abeja. So I don't know whether you refer to it because, because that we only show that at least it is increasing, or at least the detection rate, because then of all her screening, she could detect only a case. But her complaint then was that they were dying more frequently before she could. So why I say so is that you only referred to LUT in your comments, that is similar to LUT. Well, the issue is that at least in Ibadan, there appear to be an upward trend. Then I can also see that although you pegged it to less than 1,500, the range was actually nearly 2,000. Is there any explanation why you extended it rather than leaving it? Because it's important so that others who may want to do a similar study may find reason range of 1,950. And then to congratulate you, although a bigger congratulation will come tomorrow on the effort. It's not really easy, you know, to sit down and produce what you produce. Thank you, and I enjoin others to please do whatever you can to bring in local content to what we are doing. What he has done is local content. The other plea is in other didactics. Maybe we find a way